presentation, we are going to talk about the trypanosoma brucei gambiense, or the sleeping sickness. Human African trypanosomiasis are also known as sleeping sickness, and it is also a vector-borne parasitic disease. It is caused by protozoans of the genus Trypanosoma, which is transmitted to humans by bites of flies or the Glossina, which have acquired the parasite from infected humans or animals. Flies inhabit sub-Saharan Africa and only certain species transmit the disease. Rural populations, which depend on agriculture, fishing, animal husbandry, or hunting, are the most exposed. In many regions where flies are found, human African trypanosomiasis is not. The disease has a focal distribution ranging from the single villages to entire regions, and the incidence can vary from one village to the next. In this video presentation, we are mainly focused on West African trypanosomiasis, in which it is also called as the Gambian sleeping sickness that caused by a parasite called Trypanosoma brucei gambiense, it is carried by the fly. In recent years, 7,000 to 10,000 new cases of West African trypanosomiasis have been reported to the World Health Organization annually. So, 24 countries in West and Central Africa, it is responsible for 98% of cases, and this is a chronic disease that progresses over months to years.
The first unequivocal observation of trypanosomes in human blood was made by the British colonial surgeon Robert Michael Ford in 1861 to 1948. In 1901, when he examined a steamboat captain in the Gambia, he first thought that the organism he found were worms, but the English physician Joseph Everett Dutton in 1874 to 1905 identified them as trypanosomes. A few months later, and proposed in 1902, the species named Trypanosoma gabiemsi, now the Trypanosoma brucei gabiemsi. In the same year, the Italian physician and pathologist Aldo Castellani, in 1878 to 1971, found trypanosomes in the cerebrospinal fluid of a sleeping sickness patient and suggested that they cause sleeping sickness. So, in Trypanosoma brucei gabiemsi, found in 24 countries of West and Central Africa, currently account for 92% of reported cases and causes a chronic illness.
Ayan po. So, let's proceed po sa morphology po ng parasite na po ito ng Trypanosoma gambiens. So, the parasite are microscopic. So, meaning po, ayan, cannot be seen with our naked eye. From the word microscopic po, micro. Ayan, so, ang parasite na po ito ay flattened and pointed at the both end po. Ayan, so makikita po natin po doon po sa picture. Ayan, so yung mga pink po dyan, ayan, yan po yung trypanosoma po. So, nakita po yun sa, yung picture nakita po yan sa blood smear po ng human. So, kung makikita po natin, meron po siyang flattened po siya at pointed po yung kanyang both end po. So, it is an elongated spindle-shaped organism with blunt posterior end and with finely pointed anterior end. So, blunt po meaning less sharp po na posterior end po. So, posterior lang po natin. Posterior ay backward dorsal. So, yung ano po niya, yung parang tail po niya. Ayan. And then, meron po siyang finely pointed anterior end po. So, itong parasite na po ito ay actively motile flagellate po. So, meaning, active movement po sa liquid po and also sa mga solid surfaces po. So, Trypanosoma gambiens po ay typically eukaryotic cell po siya. And meron po siyang measurement po na 10 to 40 micrometers sa length and 2.5 to 10 micrometers po sa width. So, ang Trypanosoma gambiens po is morphologically indistinguishable from Trypanosoma brucei.
Next, we have the antigenic variation. What does antigenic variation mean? So basically, it is a mechanism by which a bacteria alter its surface protein in order to avoid host immune response. So in trypanosomes, it exhibits unique antigenic variation of their glycoproteins. There is a cyclical fluctuation in the trypanosomes in the blood of infected vertebrates after every 7 to 10 days. Each successive wave represents a variant antigenic type of trypomastigote possessing variant-specific surface antigens or variant surface glycoprotein coat antigen. It is estimated that a single trypanosome may have as many as 1,000 or more variant surface glycoprotein genes that help to evade immune response. Besides this, trypanosomes have other mechanisms also that help them to evade host immune responses.
African trypanosomiasis has two stages, the mammalian stages and the sessile stages. On mammalian stages, during a blood meal on a mammalian host, an infected sessile injects metacyclic trypomastigotes into the skin tissue. The parasites enter the lymphatic system and pass into the bloodstream. Inside the host, they transform into bloodstream trypomastigotes and are carried to the other sites throughout the body and enter the body fluids like the lymph and spinal fluid and continue their replication by binary fission. On sessile stages, the sessile becomes infected with bloodstream trypomastigotes when taking a blood meal on an infected mammalian host. In the fly's midgut, the parasites transform into procyclic trypomastigotes and multiply by binary fission. As the parasite leaves the midgut, it transforms into epimastigotes. The epimastigotes reach the fly's salivary glands and continue the multiplication by binary fission. The cycle in the fly takes approximately 3 weeks.
How does Trypanosoma brucei cause diseases? Or the Chesafly ingests Trypanosoma brucei protozoa, which multiply and develops into epimastigotes. Once the Chesafly ingests the trypanosomes, then multiply and develop into epimastigotes. So humans are infected after the bite from a Chesafly. The injected parasites then divide sila into a binary fissions, and then they will go into your bloodstream and lymphatics. Eventually, these parasites enters the central nervous system and causes neurological and behavioral symptoms. So trypanosomes evades the host immune system because of extensive antigenic. So yung antigenic na meron kay parasites, which is the glycoproteins na located doon sa surface ni parasite. So during this time, the parasite invades the most every organ in the body, and then hanggang sa makapag-develop siya ng hypersensitivity reaction, and then lead to itching, swelling, and edema. So when the parasite enters through our liver, the liver is our infiltration and fatty generation. And when the heart is invaded, there will be arrhythmias may develop leading to death. And when the brain is involved, yung sabi ko kanina na it will go in the central nervous system, which may lead to meningoencephalitis, and then also bleeding, edema, and granulomatous lesion. So, yun yung mga symptoms din na maipapakita dun kapag na-infect ka. And then next, we have the diagnosis and treatment.
For diagnosis, it involves 3 steps. First is screening for potential infection using serological tests and clinical examination. Second, confirmation by observing microscopically the parasite in body fluids. And third, staging the disease progression via clinical examination and analysis of cerebrospinal fluid obtained by lumbar puncture if needed. Early diagnosis is important to avoid progressing to the neurological stage with more complex and risky treatment. For the treatment choice depends on the disease form and the disease stage. The assessment of treatment outcome requires follow-up for up to 24 months with clinical assessment and laboratory exams, including sometimes of cerebrospinal fluid, because parasites may remain viable and reproduce the disease many months after the treatment. All anti-trypanosomals are donated to WHO by the manufacturers and distributed for free to endemic countries. New WHO treatment guidelines for gabiense were issued in 2019. 6 drugs are used. Pentamidine for intramuscular in first stage, generally well tolerated by patients. F-lornithine intravenous, much safer than melarsoprol, only effective in gabiense. It is generally co-administered with nifortimox or nifortimox F-lornithine combination therapy or NECT, but can be used also as monotherapy. The administration is complex. Nifortimox oral in second stage only is a component of NECT, which is shorter treatment with 4 times fewer F-lornithine infusions, safer and more effective than F-lornithine alone. WHO supplies NECT free of charge to endemic countries in a kit containing all the materials needed for its administration. Fexinadazole oral in first stage and non-severe second stage. To ensure efficacy, intake after a solid meal or under supervision of trained medical staff is required.